Good evening and a warm welcome to all the dignitaries present here. I am Swastika from Clarnet, serving as the allocated session assistant to ensure a seamless experience. Clarnet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that the Clarnet serves as the digital partner for this event hosted by Indian College of Anesthesiologists. So, focus of today's session is trauma assessment and care. Now, I would like to invite Dr. Jaisri Sood, ma'am, to proceed with the session. Over to you, ma'am.
Uh, Good evening. Good evening, everybody. And a big welcome to our faculty who's participating in the 222nd webinar of the Indian College of Anesthesiologists and all the delegates who are attending it. A warm welcome to all of you and a very happy World Anesthesia Day. This is a historic day, as we all know, way back in 1846, when W.T.G. Morton gave ether anesthesia in the Massachusetts General Hospital. He was a dentist, but he demonstrated that ether could produce anesthesia. And this was the time that there was a complete birth of anesthesia and its recognition. This year, the theme of the World Anesthesia Day is workforce and the life. Here, the aim of the anesthesiologists are to look after the cancer patients and make sure that they have a lot of progress from the anesthesia care that they get. And it is our duty to make sure that these patients recover faster with the anesthetic care that maybe have to be given to them. So with these few words, it's a great day of celebration and pride for all of us, because this day actually is recognized by the fraternity and all our colleagues who recognize our specialty for its advances and the techniques which has made us so advanced. So with these few words, I wish you all a very happy World Anesthesia Day, and it's a time to celebrate. Thank you very much. May I request Dr. Baljeet to please give us his welcome and words of for the World Anesthesia Day.
Thank you so much, ma'am. Well, friends, historical day that we are meeting today, and it happens to be the day when ICA webinar is conducted every Wednesday. So, well, when we think of the past times, it's very hard to imagine what it might have been likely to be held by strong men while the surgeons cut and stitched. And then came a messenger of God. Sorry. And then came a messenger of God, William Thomas Green Morton, on 16th October 86, who showed to the world that surgery need not be painful and a harrowing experience. The patient Gilbert Abbott was put to sleep with inhalation of ether, and John Warren, the surgeon, under the dome at the Massachusetts General Hospital, operated on the neck of that patient, and the patient did not remember anything of the pain or of the surgery. It was a path-breaking moment in the history, which is considered to be one of the greatest discovery of mankind, and indeed a priceless gift to the humanity, a gift that we all cherish every single day. It's very aptly inscribed on his tombstone, W.T.G. Morton, inventor and revealer of inhalational anesthesia, before whom in all time surgery was agony, by whom pain in surgery is averted and annulled, since whom science has control of pain. How beautifully summed it up. Well, a great salute to the great man, and who has shown us a path. And indeed, this was the birth of a new specialty that we are all celebrating today. Very happy World Anesthesia Day, and let the celebrations begin after a few more messages in the form of, the celebrations begin with the scientific program after a few more messages. Thank you so much. Over to you, Dr. Sanish. Dr. Murli, you can take over.
Yeah, sure. It's a great pleasure and delight for me to invite you to the 222nd webinar of the Indian College of Anesthesiologists. Thank you for joining us. And also, I take great pleasure and delight in wishing you a very, very happy World Anesthesia Day. As mentioned before, October 16, that is today, 178 years ago, that is in 1846, at the operating rooms of Massachusetts General Hospital in USA, W.G. Morton first publicly demonstrated the use of inhaled ether for surgery of the removal of the neck tumor. And at the end of the surgery, the surgeon remarked that anesthesia is not a humbug. It is not a humbug. That's a very, very important statement which was made at the end of surgery because patient did not feel a pinch of pain. Now anesthesia has grown tall and extended its arms to include intensive care medicine, emergency medicine, pain palliative medicine, transplant medicine, and so on and so forth. And most important thing which we mark in today's clinical scenario is that we deal with very sick patients, elderly patients, patients with many morbidities, and we are able to tackle the anesthesia bit of it without any untoward event because of the advances in this field which have taken place in the last 3-4 decades. With this, I would like to request, I would like to wish you a very happy World Anesthesia Day and request the host to play the videos of messages from Dr. Baljit, Dr. Radhakrishnan, and Dr. Sanish. Thank you. This is Dr. Radhakrishnan's message, who is the Chief Trust and Academic Chairman.
Good evening. Welcome to Indian College of Anesthesiologists. Indian College of Anesthesiologists convey you the greetings of the day. Well, in the last 30 years, we developed beyond any level of comparison. Even today, we are the youngest self-standing specialty of medicine, and we achieved a lot, and we're going to achieve further with the help of artificial intelligence augmentation and further newer pharmacology advancements which are coming to us. Friends, at this juncture, what I would like to say is that, well, we are developing, but we should have some motives, some goal towards our future life, because we need to all recalibration for the basic skill, or I may say basic skill updating during a particular period of time is necessary for everybody. I may say every 5th year. Well, one should upgrade the basic skill and should learn the advanced skill from whatever occurring all around the world. We have to be conversant with all the academic developments which are coming up. Maybe the conferences or say publications or the education programs which are going on around the globe are the ones which are going to help you. So you should have the basic skill updating done every 5th year to make you well tuned to what is the basic skill again. And again, advanced skill, as you go along, you have to learn. And concentrate place in the work culture quality. That means your work is going to be notified by the quality of what you're going to deliver. And again, safety to your patient as well as well-being of yours. And 2024, the World Federation says about the well-being of people around you, because we all going to advance with all the people around, because we are interested in an inclusive growth, and let this inclusive growth take us forward. Whereas in 2023, the theme was cancer care, also the pain relief in the cancer care, as well as in 2022, it was a medication error. So medication error is now settled, negligible incidents of errors happening. And the cancer care, well, just come one step forward in the availability of narcotic drugs and the standardization of the use of narcotics all around the globe. And now we focus on the workforce, or say welfare of people all around us. So my friends, well, enjoy comfortable living, help others, and be a good Samaritan. Wish you all the greetings once again. Thank you.
Hi, I am Dr. Sanish. I am happy to offer greetings on the occasion of World Anesthesia Day 2024. These are the different aspects or dimensions of an anesthesiologist's career. Colleagues are important, so does seniors' involvement, their advice. Of course, we need to go hand in hand with our surgeons. We can't underrate the role played by the anesthesia or theatre technicians, the nurses, and in teaching institutions, the students, and the support by the hospital administration. Above all, the personal well-being and the family well-being also gets translated into a comfortable and safe anesthesia practice for all of us. So, we need to merge all these dimensions together to build up a good workforce well-being. Yes, our job is tedious, we need to concentrate, but when we have free time, do take a moment to relax a bit. Be proud anesthesiologists. Greetings on the occasion of World Anesthesia Day once again. Thank you.
Thank you very much. And can you hear me?
Yes.
It's a great pleasure for me to introduce Dr. Shaloo, the Professor of Anesthesiology and Critical Care Medicine, Amrita Institute of Medical Sciences at Faridabad. Thank you so much for joining us, and it gives me great pleasure to welcome you and introduce to the audience today. And with Dr. Shaloo, we will be having Dr. Vivek Chopra, again from the same institute, a professor, and Dr. Niti Batra, who is a senior consultant in anesthesiology and critical care. I would like to welcome all the three faculty members for today's evening session. And over to Dr. Shaloo, and we are looking forward to a great session on trauma assessment and care. Thank you so much once again, and we are looking forward to your presentations. Thank you.
Thank you so much, Dr. Muralidhar. I'll start sharing my presentation now. Very warm welcome to all of you who have joined us today for this particular webinar, especially on the occasion of World Anesthesia Day. A warm greeting to all of you on World Anesthesia Day too. Today, I, along with two of my colleagues from Amrita Hospital, would be sharing some insights into trauma assessment and care in extremes of age. So we shall be covering the pediatric age group and the geriatric age group. As Dr. Muralidhar said, the anesthesiologists have been diversifying into various other specialities, which included critical care to begin with. Then it has moved on to trauma care, onco anesthesia and transplant anesthesia too. So taking it further from there, we will just share some insights into trauma care today and see how, as anesthesiologists or as ER people, we can help in the assessment and care of these patients. Trauma care, as we all know, is the most common non-communicable disease which leads to death. However, it is also one of the preventable causes of death. So why are we still lacking behind? India shares a large trauma burden and the death related to trauma. And also, sadly, in our country, trauma care is still in a developing stage with no organized sector. But the good news is that a lot of societies talking about trauma care, Society of Trauma and Anesthesia, Anesthesia Society for Trauma is coming up. These are helping people in getting a focused training in trauma care of the patients, and also they are helping in setting up trauma care facilities in various large hospitals as well as small hospitals, where a patient, as soon as he or she arrives into the trauma care, can be taken care of. Mr. Gadkari, our Minister for Highways, also was very focused on reducing the preventable deaths which happen due to road traffic accidents. As we all know, that India is expanding its infrastructure greatly. So the large tier A cities see a lot of road traffic accidents and deaths because of high-speed motor vehicle accidents. Tier B cities are also rapidly expanding. And other than the high-speed deaths, what brings about a lot of trauma there is a very poor sense of road safety and traffic rules. These are leading to more and more statistics of road traffic accidents and deaths due to trauma. So without taking any further time, I would start my talk, which is on initial assessment of trauma victims. So in the next few minutes or so, I would talk about what is the importance of initial assessment and how we can do assessment of the trauma victims. Like I said, India shares 20% of the world's trauma death burden. If you take the numbers, then it is almost 2 lakh deaths per annum which happen as a result of trauma. There are deaths which happen immediately on sustaining the injury, which is at the scene, and these are greatly non-preventable. They cannot be avoided because they are related to injuries to the great vessel, to the heart, or a very serious injury to the brain. What we are looking at in assessment is the deaths which happen because of early injuries. And early injuries, the cause can be hemorrhage and cardiovascular system collapse, which can happen to the patient as soon as the patient arrives into the hospital. Then the late cause of death, again, it can happen in the hospital, which can happen over the next week or month, is because of the sepsis and multi-organ system failure. Early deaths, 50% of them happen in the hospital, but 50% of these deaths were deemed preventable in the hospital. So identifying the patients who are at risk of early mortality, especially within the 24 hours of hospital arrival, is essential for triaging of the patients and a good assessment and further management of these patients. As we all know, in our country especially, trauma victims are usually not seen or picked up by paramedics. They are usually seen, attended to by the bystanders. And as far as these bystanders are concerned, they have absolutely no knowledge about how to handle the trauma victims. And so they just pick up the patients and walk to the nearest possible medical facility available. Therefore, we have no on-scene triage available. No triage happens in the field scenario. Thus, triage is most of the time done once the patient has reached the emergency department or the trauma department of the nearest medical facility available. We should understand that there are plenty of signs which a patient has, which will tell us indirectly about the 24-hour in-hospital mortality, which is likely to happen. These include if a patient has a moderately to severe GCS score, if the blood pressure at the time of receiving was less than 90 millimeters of mercury, the systolic pressure, whether the patient had bradycardia or tachycardia, if the saturation was less than 90%, or if the patient had tachypnea or even hypopnea or respiratory rate was less than 6 per minute. These patients have a higher incidence of mortality associated with trauma within the next 1 day. Thus, for us to be able to have a pre-hospital notification, to be able to take care of these patients better, we need to have a very good coordination with the clinician who's receiving these patients in the hospital. With the emphasis upon the airway of the patient, we should know whether the patient is breathing, not breathing, whether he has an airway secured, or is the patient able to communicate. So we know that the airway does not need to be secured right away. Whether there is any external bleeding and whether it has been controlled by application of pressure, or if the patient is in shock, whether the patient has been immobilized. Immobilization, especially with respect to the spine, the cervical spine, or if any long limb fractures, which have the fracture segments have been immobilized to prevent any further injuries. And where the patient is being transported, is it to the nearest appropriate facility or not? So to give a brief overview, there is a revised trauma score where numerical value is assigned between 0 to 4. And to keep it very simple, just 3 parameters are looked at. One is the Glasgow Coma Scale, the other one is the systolic blood pressure, and then the respiratory rate. If the trauma score is 12, that means this patient's transfer to the facility can be delayed. You can take care of some other patients who have a trauma score of 11. These patients have an urgent need to be transported to the nearest trauma center. If a patient has a score of 3 to 10, it is an immediate requirement that this patient must be reached to a place where he can be taken care of. If a patient has a score of 3 or less than 3, then these patients are unlikely to survive. And in situations where there are mass casualties, maybe we can ignore these patients and take care of patients who have a score of 3 to 11, where there is a chance that these patients will survive if given a care. So coming to pre-hospital notification, how can the pre-hospital notification be made easy to understand and easy for everybody to know what the patient is likely to be? So we go by the pseudonym MIST, M-I-S-T. What M stands for is the mechanism of injury. This is very important because if we know the mechanism of injury, we are able to know that what are the likelihood of injuries which this patient could be having. I stands for the injuries, where you actually tell the person receiving the patient what are the injuries which you have been able to make out this patient has, whether it's a maxillofacial injury or a injury to the femur or injury to the chest or thoracic trauma. S will be signs and symptoms. So like I said, be very quick, very brief. Let us know whether the patient is breathing or not, talking or not, heart rate, blood pressure, saturation if possible. And T, of course, is the treatment administered. So on field, the paramedics usually would have immobilized the patient on a spine board, put a cervical collar, maybe may not have secured an IV access, and maybe may not have secured the airway. So these are the quick 4 things which they should communicate to the hospital before moving with the patient from the scene. I will just share a couple of pictures which will tell us what mechanism of injury would let us know. This is a picture showing a head-on collision of a car at a high speed with a tree in front. So we know that this injuries which the patient would have likely sustained is because of the frontal impact onto the head, because of the hitting of to the windshield, the forward momentum and the force of the impact of the steering wheel could have led to injuries to the thorax, especially to the retroperitoneal structures. The lower limb would be injured because of the hitting with the dashboard and upward transmission of weight through the floorboard. So again, the spine would have been injured. So just knowing that a patient has had an injury with a high-speed motor vehicle head-on collision, 3 to 4 major injuries can easily be thought about for these patients. Next is a picture showing a gentleman on a ladder trying to move a huge beam. And as the beam gets displaced, it comes and hits the abdomen of the person, causing him to fall from the ladder. So with this history, we will know that yes, he will have some abdominal injury. So we should be looking at the solid organs injury. And because of the fall, he's likely to have musculoskeletal injury, injury to his spine and injury to his shoulders, etc. Another picture here shows a person having sustained a bullet wound injury to his face. Here the entry of the wound is on the right side of the face and exit is around the mandible on the left side. So again, this will tell us that the patient may possibly have a compromised airway. There could be disruption of some major vessel in the neck, and we will probably need to secure the airway of this patient as early as possible. So some of these pictures showing the mechanism of injury. Thus begins the triage of the patient. Once you receive the patient or you have an idea, you sort out the patient. Why is it important? It is important because we should know what are the resources required for the treatment based on the information we have received from the site. And number two, to determine whether we actually have those resources available with us to handle such patients. What is the severity of the injury and whether the patient has the ability to survive. If we have these things in mind, we will be very clear in our mind and be able to sort out the patients and decide whom to attend to first. So we've all heard of situations in the news channels and the TV, multiple casualties, mass casualties, but there has to be some difference between the two. Multiple casualties is when the number of patients and the severity of their injuries do not exceed the capability. For instance, if we are told that there is a multiple casualty scenario somewhere in South Delhi and the patients will be transported to the trauma center at near AIIMS, we know that there are multiple casualties because the system has the ability to handle all these patients. There can be life-threatening problems and those sustaining multiple system injuries, but the institution will be able to handle these patients. However, if the same injuries are happening at a remote area in a train accident at a remote area and being transported to a primary health center, it becomes mass casualty. Why? Because the number of patients and the severity of that injury does exceed the capability of the system which is going to handle these patients. So here we look at the patients who have the greatest chance of survival, who will require the least expenditure of time, equipment, supplies, and the personnel. That way, we will be able to take care of a larger number of patients, attend to them, and then transport them to further higher centers for subsequent management. So once we have received the information, we have kind of triaged the patient, going to triage the patient, we have to get into the preparation mode for receiving all these casualties. So what do? You activate your trauma team. In an ideal scenario, in an institution with trauma team, this is what a trauma team would look like. Head end would usually be with the anesthetist. The anesthesiologist will be assisted by one nurse. There will be a surgeon who will be attending the patient, and he or she would be the team leader, or in some situations, even the anesthetist could be the team leader. There will be an emergency physician. There will be one or two nurses extra. And depending upon the information that you receive about the patients you are going to receive, you would give an advance information and get the neurologist and the radiology technician also available on site once you are ready to receive the patients. So if you see a trauma bay, a dedicated resuscitation bay or a trauma bay is what it would look like. At the head end will be all the equipment which will be required for the airway management of the patient. All the drugs will be there and the monitoring system. A nurse and a doctor will be on the head end again to take care of the airway, assist the patient, doctor for the airway, and also hand over all the drugs, etc., which need to be administered. On the either side of the patients will be Dr. 2 and Dr. 3, which in most situations would be a trauma surgeon or a surgeon, neurosurgeon also, with nurses to assist them. All the procedures trolley will be on one side and the storage space on the other side, so that people do not have to keep running in and out of the resuscitation area to go and fetch items, because time is at premium in this situation. At the foot end would be the team leaders. That could be a surgeon or an anesthesiologist. In most scenarios, I will be telling about the role of the team leaders. The team leaders usually stand, observe, and give instructions as to what is to be done, with a wider perspective about exactly what is happening in the situation where the patient is being resuscitated. So the hospital preparation begins with simple A, B, C, D, E. With A means airway equipment, you have your laryngoscopes and endotracheal tubes of appropriate size, working condition. B will be for breathing, so you have an ambu bag with a source of oxygen to ventilate a patient if required. C for circulation, IV crystalloid solutions, preferably warmed, with correct bore IV cannulas and IV tubings, etc. available. Then monitoring, basic monitoring of heart rate, blood pressure, saturation, capnography should definitely be around. Assistance, like I said, additional assistance in terms of nurses, laboratory and radio personnel must be sought after because some of them will be staying away, they will be on call. So they can at least make themselves available by the time you are ready to receive the patients. Transfer agreements with verified trauma centers are established and operational. In case you are not at a trauma center, Apex Trauma Center, you must know that if you receive trauma or casualties, where next would your patient subsequently be transferred to? So these kind of situations, if you already have agreements in place, you do not waste time when you are ready to transfer out the patient after initial resuscitation. So how do you do the injury severity score? The body has been divided into various parts, and there are over 2,000 injuries which have been described, which can be from head to toe, spine, lower extremity, etc. And the score has been given as an abbreviated injury scale on a scale of 1 to 6. 1 is a minor injury, and a score of 6 means the patient is unlikely to survive. So you take 3 highest scores of whichever is the part which is injured. Let us say if it is a head, face, and thorax, you take injuries, 3 highest scores, you square them up and add them. The score is detailed as between 1 to 75, where 75 is the maximum score. However, the thing to remember here is if a patient has any injury where you assign a score of 6, it straight away becomes a score of 75, and that means this patient is unlikely to survive the trauma which he or she has sustained. Some of the examples of these injuries are minor will be an isolated rib fracture, a moderate injury would be testicular avulsion, a serious injury is a simple hemothorax. Score of 4 for severe injury could be a below knee amputation with a bleeding wound. 5, critical injury will be femoral artery injury and more than about 20% of blood loss and ongoing blood loss. Unsurvivable injury becomes torso transection or a neck transection, etc., where you find that there are major airway traumas. So once the patient has been received, how do you proceed with initial assessment? You do a primary evaluation with simultaneous assessment. They do not exist in exclusion. They have to go hand in hand. Spend 30 seconds in assessing a patient. Go as per the basic alphabets A, B, C, D, E, airway, breathing, circulation, disability, and expose the patient. You identify what are the life-threatening conditions which need to be tackled fast and prioritize the treatment accordingly. So this also will mean assigning work to your team. So team will include team leader. The team leader usually will supervise, it will keep a check, and it will direct the assessment, assign the roles further to the other doctors and the nurses and the tasks. He or she may not ideally be involved directly in the assessment or management of the patient himself. The roles will be assessing, including airway assessment and management, undressing and exposing the patient so that you do not miss out any injuries, applying monitoring equipment, obtaining IV access, drawing blood for basic lab samples and blood grouping and cross-matching, which is very important, and recording of resuscitation activity. This recording of resuscitation activity is extremely important. We usually do not give too much of credence to this particular activity. However, if you are able to record the activity, one, it keeps a tab on whether you have done the thing properly or not, and you can redirect the person to the correct path. Number 2, it also helps us in a debrief, and it also helps us in learning what were the deficiencies in our assessment and management and how we can improve upon it further. This helps in a lot of teaching and training for the team. In the airway, what you need to know is the patency of the airway. If the patient is shouting in pain, rest assured his airway is patent. We don't have to worry much about securing the airway. If there is any foreign body, needs to be removed. Fractures, especially the maxillofacial fractures or the mandibular fractures, can compromise the airway. Cervical spine stabilization is extremely important. Before we embark upon managing the airway, we must ensure that the cervical spine is stabilized so that if there is any fracture which is critically placed, we should not make it we should not cause further injury to the spine. A very good suction of the oral cavity. So for that, we should have a working suction machine. Jaw thrust, chin lift, depending upon what the injury is. Securing the airway. That means we put a cuffed endotracheal tube if the patient has a compromised airway or risk of aspiration. And there are conditions where there could be progressive airway loss, like burns sustained in the upper airway, or like the picture I showed where there was a bullet injury. Then the patient was talking coherent, but subsequently there can be loss of airway once the edema, etc. sets in. Next, coming to B, breathing. We need to do oxygen supplementation of the patient. If the patient is talking, airway control is not required, we can just supplement with oxygen. Otherwise, take control of the airway, ventilate the patient. Inspect the thorax, auscultate the thorax to see if there is any problem in the thoracic cavity because of which breathing could be affected. In circulation, first thing is to look for hemorrhage, the site of hemorrhage, and whether it can be controlled by external pressures, direct pressures, and simultaneously continue resuscitation with warm crystalloids. Meanwhile, when the IV line is placed, we have already drawn the blood, sent for grouping cross matching, ask for blood and blood products. If there is tension pneumothorax, this can compound the problem because the patient's blood pressure will be, you will find that the patient is hypotensive, tachycardic. You give fluid, it does not improve. You have to think about tension pneumothorax where there can be circulation compromise, not because of hemorrhage, but because of tension pneumothorax. Evaluate the patient by his pulse, level of consciousness, and skin perfusion. Because if there is hypotension because of hemorrhage, ongoing hemorrhage, the patient's organ perfusion will be affected. And because of that, the patient will have reduced level of consciousness. The skin will be cool and clammy. It will tell you that there is an ongoing hemorrhage and there is hypotension because of that. Good IV access, lab samples, blood grouping cross-matching is required. Keep warm crystalloids, blood, some plasma, and tranexamic acid also because it has been found to help in the bleeding which has been sustained because of the trauma. If the bleeding is external, we can apply manual pressure, especially if it's a long bone, etc. Splint fractures, a tourniquet can be applied, and then we can take the patient for X-ray chest, pelvis, and fast. Basically, we can think about chest decompression, pelvic binders, and splinting to the extremities to prevent any further injuries. And do think about definitive management, especially intervention radiology or surgery. A disability, a rapid neurological evaluation in terms of Glasgow Coma Scale, traumatic brain injury. Do think whether the patient is under the influence of drugs or alcohol, because this can compound the higher mental function of the patient, and we would be thinking that the patient probably has neurological injury. Take care of perfusion and oxygenation so that we can avoid secondary brain injury to the patient. Expose the patient so that you do not miss out any injury, especially onto the back of the patient or the posterior aspect. However, take care that you do not cause hypothermia to the patient. So cover the patient with warm blankets, give warm IV fluids, and force warming air by using the force warming air device. Adjuncts to be used will be the monitoring like ECG, pulse oximeter, end-tidal carbon dioxide, ventilation, ABG if indicated, catheters, orogastric catheter or a nasogastric catheter, and a urinary catheter. X-rays like chest and pelvis if indicated. FAST and EFAST have made a lot of assessments very quick and efficient for us to know whether there is any blood or any in the thorax or into the abdominal cavity. Secondary evaluation only after improvement in the vitals, where you take the history of the patient, ample history, which means A for allergy, medicines, P for past illness, last meal, and events. In the medicine, it's very important to know if the patient was on any dual antiplatelet agents, etc. So you know that the patient is likely to have bleeding, or any beta blockers. So the patient may not have tachycardia. However, his cardiovascular system could be compromised. Missed, like I've already described before, head-to-toe evaluation and reassessment of vital signs. Here it is important for me to stress that at any point of time where you find that the vitals of the patient are again deteriorating, you must go back to resuscitating the patient before proceeding with further assessment or further investigations for the patient. The adjuncts which I have mentioned, re-evaluate and do think about definitive care at an early stage. If you have the capability, you should activate your definitive care system. If not, then you should get ready to transfer the patient to a definitive care facility. So to summarize, in trauma cases for assessing a patient, firstly, it is on-site once you receive the information for trauma and you reach the site. Pre-hospital notification is very important for the hospital to ready itself to receive the patient. In the hospital, they must activate the trauma team, and the resuscitation bay should always be ready for receiving any casualties. The trauma reception should be ready with all the drugs, etc., which I have said. As soon as the casualties received, triage should be done, and an initial assessment should be started immediately. A quick history, if the time permits, for missed and ample to be taken. Repeat the assessment frequently. Do keep going back to assessment while the resuscitation is going on and while you're moving on to secondary assessment of a patient too. And definitive care as soon as vitals are stable. So this much for the assessment of a trauma patient. Thank you very much. We will take all the questions at the end of the webinar. And now we will move on to the second talk of the day. The second talk of the day will be by Dr. Vivek Chopra. He is also a professor and senior consultant anesthesia in Amrita Hospital, Faridabad, a senior colleague who has extensive experience in the army. He shall be talking about the anesthesia. He shall be talking about trauma in pediatric age group patients. Over to you, Dr. Vivek.
Yeah, started.
Hello, sir. You're on mute. Can you please unmute yourself?
Yesterday we had
So after your screen sharing, just open your keynote.
Is it still not open?
No, sir, it's not visible.
My keynote is not open, visible.
So your screen is not shared yet.
Just a minute, please. Share screen. Is it sharing now?
No,
Not
no,
yet, sir.
no, not.
So can we have Dr. Niti to present the case before, by the time Dr. Vivek figures out what is happening to the screen sharing? Dr. Saloni? Swastika?
Sure, ma'am.
Can we
Sure.
can we request Dr. Niti to start with her talk?
Yes, ma'am. You can do that.
Okay, fine. So we are sorry for this small glitch in the technology. We will request Dr. Niti to start her presentation. She will be talking about trauma in geriatric care. Dr. Niti is at Amrita Hospital working with us. She's a senior consultant in anesthesia. She's a very bright, sprightly anesthesiologist who takes part in, who loves to teach and takes part in multiple webinars and multiple workshops teaching students the BLS, ACLS, as well as airway, etc., and also ultrasound. So today she will be telling us about trauma in geriatric care. Over to you, Dr. Niti.
Hello, am I audible?
Yes,
Yes,
you
ma'am.
are. Yes, you are.
A very good evening and a very happy Anesthesia Day to all of you. Thank you, ma'am, for the kind words. So, I'll be speaking upon the geriatric trauma. Are elderly more susceptible? So, aging is of the population. Aging of the population is the most social transformation of 21st
Yes, we
century.
can hear. We can hear you.
Okay. So aging of the population is expected to be the biggest social transformation of 21st century. We are expecting the age to increase, that we are having the generation which will be living more than the previous generation, and they will be access to the better healthcare. So we'll be having a more proportion of the elderly population. So what is an elderly? Is it more than 55 years or is it more than 65 years? So they have got a different age group given in different studies. But what is most important? The most important is the physiological age rather than the chronological age. So trauma is the fifth leading cause of death, out of which 75% is fall. That is a trivial fall. So the mechanism of injury can be same in any age group, but an elderly poses a unique challenges. And as pediatrics are not younger adult, similarly, geriatric age group is not older adult. They have got their unique challenges that we'll see that their physiology has got a different implications. So we need to give them special attention because they are vulnerable. So are they more susceptible? Yes. So we'll see in the subsequent slides that what are the physiological changes and their implications, how we need to collaborate the physical examination and various investigations. We have to see the pre-existing conditions they have, frailty index, specific injuries and specific concern with them, the medication history, the cognitive and sensory impairment, palliative and multidisciplinary approach has to be followed. So trauma, the mechanism of injury can be same, but a very trivial trauma, a very low velocity trauma can cause injury. Most common being fall. No, why should they have fall? Why we have to find out what was the cause of that fall? Whether it was because of the poor lighting, neurocognitive dysfunction, anemia, neuropathy, use of ambulatory aids, or it was a dysrhythmia, and what were the medical conditions of the patient, and whether he was on multiple medicines especially the risk factor increase if there is a polypharmacy of more than 6 medication. One fall increases double the chances of second fall. Then is the motor vehicle crash. Although they travel at a very slow speed, the accidents are usually seen during the daytime, but the reason being a slow reaction time, cognitive impairment, and they may be using vision and hearing aids. Burns also is more common if they are elderly. They will have increased losses because a young can reepithelize faster, but not an elderly age group. So if it is more than 50 years with more than 10% burns, they need a special burn care hospital. Less common causes are penetrating injury, suicidal, because the increase of depression, then assault. So as ma'am has already said that we follow the same principles of ATLS. So in the primary survey, that is the airway and the C-spine stabilization, what is most important here? The elderly have got difficult mass ventilation and difficult intubation because of the arthritic change. Neck extension is restricted. They are using dentures. So what we can do, we can put dentures for mass ventilation and then remove the dentures while we are doing intubation. We need bougie and we need judicious use of airway and supraglottic air. Then second implication, they have got loss of protective reflexes or they have got decreased protective reflexes. What does that mean? That they are being exposed more to aspiration. So we need to have early securing of the airway. Second is breathing. So what is the change in the breathing? They have got decreased FRC, decreased gas exchange, emphysematous changes, loss of elastic recoil, and decreased mucociliary clearance. Rib fractures are more. So what does it imply? That they need good analgesia. The chances of pneumonia are high. Respiratory failure occurs early because they cannot auto-regulate or they do not respond to hypoxia, hypercapnia. Circulation. So what is there in the circulation? Like youngsters, they cannot respond well to the hypovolemia and shock. So there is a loss of physiological response to hypovolemia. Why? Because of the certain medications like beta blocker, because of their pre-existing condition. There is no auto-regulation because of the down-regulation of catecholamine receptors. Their vessels are atherosclerosed. So there is a failure to recognize shock. We need to have more markers like shock index, serum lactate, and base deficit in these patients. So if shock index is more than 1, serum lactate more than 2.4, base deficit more than 6, that implies shock. So our target should be systolic above 110, heart rate above 90 per minute. And we have to collaborate with the invasive monitoring with the use of volume status by the point of care ultrasound. So we can use point of care ultrasound for the assessment of volume status. We can use arterial line monitoring. Along with that, we can use the pulse pressure variation and stroke pressure variation. Then is the disability. So there is a cognitive and sensory impairment. Because of cerebral atrophy, they present late. And because of the drugs like direct oral anticoagulants, there is a high chances of bleeding. Even though your CT scan initially is normal, we should observe this patient longer and we should not delay using contrast. We can go with the contrast. Then we can repeat the CT scan after 6 hours. There is bleeding that we need to reverse the anticoagulants. Then there's a delayed presentation also because you are not able to differentiate the traumatic brain injury with 3 Ds: delirium, dementia, and depression. So there is a confusion whether this is traumatic brain injury or the patient is having cognitive impairment. That patient might be a Parkinsonism patient. Then there is a bone loss. So there is a more injury to the spinal cord. So there is a spinal cord injury without obvious radiological evidence of trauma. So we need to have aggressive therapy, aggressive use of investigations. Then in the E, that is the exposure and the environment factor, there is a loss of muscle and fat. The bone density is less. There is a loss of skin elasticity, and there is nutritional deficiency. So what does this implies? That we need to take measures to prevent hypothermia. They can have severe blood loss, and we have to early release the spine board and the cervical collar and take a use of pressure padding. In this primary survey, there is an F which is very important. That is the frailty, trauma-specific frailty index. Because effect of frailty on mortality persists in less severe injury pattern. Even though the injury mechanism of injury is same, injury score is less, but because of the frailty, the mortality increases. Then there is a comorbidity polypharmacy score. There is a negative association between polypharmacy and trauma outcome with comorbidity. Now we move on to the secondary survey. So what is important in secondary survey? We have to use aggressive investigations, and we have to collaborate many things like early use of ultrasound focus, CT scan. We have to screen for delirium, and we have to control the modifiable factor, because delirium is the day-to-day change. It is an acute neurocognitive change affecting attention, awareness. So what are the modifiable factors? The modifiable factors are optimizing sleep, optimizing pain, hearing, vision, and the cognitive. So we have to take care of the frailty index also. By the confusion assessment method, we can assess and screen for the delirium in these patients. Also, what is the next most important thing is the detailed medication history. So there's a Beers criteria which says that we have to screen. There is a screening tool to alert doctor to write treatment. Screening tool of the older patient's prescription. So in elderly patient, this history is very important regarding the medication, regarding the baseline function status. Then we have to assess the cognition. There's a mini cog test in which we ask them to draw the clock, or we can ask them to have 3 items recall. So these are the reliable indices that we use. One is the shock index, which is the heart rate divided by the systolic blood pressure. 0.7 is occult shock, more than 1 is shock. This along with the base deficit and lactate levels. There is another respiratory adjusted shock index. That is the shock index into respiratory rate divided by 10. If it is more than 1.3, it says occult shock. So there are the various scales that we use. So frailty index is very important. The chronological age is not important. What is most important is their physiological age, how frail they are, what is the polypharmacy and comorbidity score. In frailty, it is fatigue, resistance to climb 1 flight of stairs, ambulation to walk 1 block, illnesses more than 5, loss of weight more than 5%. If it is more than 5, it is burst. 3 to 5 is frail. Then there is another geriatric trauma outcome score, which is also very good score. This is age plus 2.5 into injury severity score plus 22 if pack red blood cell transfused in less than 24 hours. This is used as a prognostic indicator for in-hospital mortality. In this study also, 2023 guidelines on the management of trauma in the elderly and frail patient, they have emphasized the importance of frailty index in having the mortality prognosis of these patients. This is the injury severity score, which has already been discussed by ma'am. So now we come on to the specific injuries that we see in the elderly patients. Rib fractures are frequent. That means they get pneumonia early in high chances. So we need to take care of pain and the pulmonary hygiene. Then next is the pelvic fracture due to bone loss and balance issue. So blood loss is more. There is a prolonged stay in the hospital. So in this case, we have to look for the respiratory and pneumonia changes also. Studies have found out that general anesthesia or regional anesthesia, they both fare same in the long-term course. But there is an increased risk of post-cognitive dysfunction in the hip fracture post-operative elderly age group. Then most important is the traumatic brain injury. Why? Because of cerebral atrophy, rupture of bridging veins is frequent. They have already got delirium and dementia. You have got a delayed diagnosis. They won't know just a trivial fall, and these patients will come later on to you with the change in the cognition, change in the memory, and change in the behavior of the patient because there is a slow development. So there should be a liberal use of CT scan. And if these patients are on anticoagulants, we need to reverse these anticoagulants by the use of prothrombin complex concentrate and fresh frozen plasma. So how to proceed in this patient? The most important is history. So what do you need to ask in the history? Their baseline functional status, their pre-existing conditions, and their polypharmacy. Now, what is the mechanism of injury? Even though the mechanism of injury is same in young and elderly, the trivial fall will cause more injury in elderly. Then your pre-existing conditions like cirrhosis, coagulopathy, diabetes, chronic obstructive pulmonary disease, and coronary artery disease. Then you need to screen their medication. You need to know their baseline functional status before trauma. You need to know their cognitive and sensory impairment. So what are the anesthesia challenges? The comprehensive geriatric assessment says that we need to know the preoperative period baseline status. What is the activity of their daily living? So this one test, that is time up and go test, is very simple to use. You ask them to get up from the chair, go walk 3 meters, come back 180 degrees, sit back. If it is still 12 seconds, more than 12 seconds, then it is significant. Then comes your frailty scoring that we have already discussed, pre-existing conditions, medication, especially anticoagulants, cognitive and hearing impairment. There is a risk of dementia 5 to 8% in more than 65 years. It becomes 1/3 with more than 85 years. Post-operative increased risk of delirium. Chances are 2% increase each year after 65 years. So we need to have a multimodal analgesia with liberal use of regional techniques. So what are the drugs that we can use? In this case, induction agents and opioids, they need reduction in dose by 50%. You have to go slow, start slow, and go slow theory for the opioids. Then, as an induction agent, ketamine in sub-anesthetic doses is good. Etomidate, again, risk of myoclonus and adenocortical suppression is there. Propofol, there is a decreased fall, exaggerate falls of blood pressure, and so we have to balance, we have to reduce the dose, or you can use the combination of ketamine and propofol. For the muscle relaxant, there is the same bolus dose, but preferably atracurium. You have to use guarded fluid therapy and early blood transfusion, I would say, in these patients. So in the perioperative management, after I have secured my ABCs, so if I see that my patient doesn't have any hypoperfusion, my parameters like lactate is less than 2, injury severity score is less than 9, little concurrent diseases. So I go with my standard ASA monitors. If the patient is in shock, the injury severity score is more than 9, there are concurrent diseases, I use my invasive monitoring like arterial line, calculation of the oxygen transport variable. So if the pulmonary capillary wedge pressure is less than 15 to 18 mmHg, you give them the volume load. If it is more than 15 to 18 mm of mercury, we give the inotropic support until the mixed venous oxygen saturation is more than 70% or my lactate drops to less than 2. Regarding this specific concern, there has to be a multimodal analgesia, acetaminophen, pregabalin, lidocaine patch, NSAIDs, peripheral nerve blocks. Avoid opioid and tramadol for the post-op. Non-pharmacological methods like ice pack and immobilization can be used. We have to have aggressive and early treatment in the terms of CT scan and focus. There has to be a multidisciplinary approach and use of palliative care team. Use of deep vein thrombosis prophylaxis whenever possible, or you use mechanical prophylaxis. Antibiotics in case of penetrating burns and fracture, considering the common bacteria causing surgical site infections like E. coli and Enterobacteriales or Clostridium. For these, we should use the antibiotic. And we have to use the reversible agent for the reversal of anticoagulants like vitamin K, prothrombin complex concentrate, fresh frozen plasma, or the specific antidote that we have for dabigatran and rivaroxaban. Because anticoagulation are a concern, especially nowadays, the patients are taking direct oral anticoagulants. So we need the coagulation assay, we need the thromboelastogram and the rotum. Anti-10A assay is gold standard for the monitoring of low molecular weight heparin. So reversal of anticoagulants is a must by use of PCC, vitamin K, FFB, and specific antidote as for dabigatran and apixaban. So the take-home message is that they are vulnerable, they are different, they pose unique challenges. Though mechanism of injury can be same, but they will have severe as per the low fall, as per the low velocity injury. So we need to have early and aggressive treatment. We should have the understanding of the physiological changes and their implications. We have to collaborate with multiple indices and various investigation like CT scan, focus, use of multimodal analgesia. Aging is correlated with frailty, and frailty is a risk factor for mortality. Very important is what is the cognitive dysfunction, what is the baseline functional status of the patient, what is the comorbidity and the polypharmacy score of that patient rather than the age of the patient. So triage issue in more than 70 years, even with minor injuries. Thank you.
Thank you so much, Dr. Niti, for that information about the geriatric trauma, which a lot of times gets neglected and probably gets ignored also, where we take, like you said, the minor injuries not very seriously, and it turns out to be a huge problem for geriatric population because their reserves are already limited to a large extent. Now we will go back to Dr. Vivek Chopra's presentation, who is going to be talking to us about trauma in pediatric age group. And over to Dr. Vivek. I think his system is working now.
Good evening to all of you. I'm sorry for that technical glitch. After having heard from my previous two colleagues, Dr. Shaloo and Dr. Niti, it's my turn now to discuss about pediatric trauma. How are children different? So greetings from Amrita Hospital and a very happy World Anesthesia Day to all of you. Not really? Oh, yeah. Huh? Take much of that.
Apologies for the technical problem, which seems to be still persisting with respect to Dr. Vivek Chopra's presentation on pediatric and trauma care. So,
Okay. I'll do that. Hold on. अभी आया है? Why is it not playing? Yesterday it did.
Swastika, are there any questions in the chat box? Shaloo?
Oh,
Hello?
ma'am, there are no questions yet.
Aaj, aaj. Shaloo, you can discuss something in the meantime while we're getting things in order. I think we can see the first slide, Vivek.
Dr. Vivek will be presenting now from my computer.
Yeah, I can
so
see
let
that,
us,
uh-huh.
hear him speak.
Yes.
My apologies for this technical. My apologies for this technical glitch. And thank you for bearing. Am I audible now?
Yes, we can hear you. सुनाई दे रहा है विवेक?
Am I?
Yes, yes, we can hear you.
So I'll be discussing about pediatric trauma. How are children different? Trauma has been discussed in details by the previous two speakers. The basic principles will remain the same, so I will not elaborate much on them now because of paucity of time as well. So injury is the most common cause of death and disability in childhood. Trauma being the most serious public health and healthcare problem in this age group. Road traffic accidents account for they are the leading cause of death in adolescents, that is children more than 13 years of age. So children are, the injury patterns in children and the types of injuries in children are different, slightly different as far as the statistics are concerned, where motor vehicle crashes is the leading cause of injuries and deaths in children of all ages. This is followed by drowning, falls, house fires, and homicides. So, however, in the Indian scenario, there have been studies conducted. There's a study published in the Indian Journal of Community Medicine, which found that unintentional injuries account for 9.1 deaths per 100,000 population, and also out of which road traffic accidents account for 2.8 deaths per 100,000 population in this age group. This study also found that over 95% of all child injury deaths occur in low and middle income countries like India. There was another study conducted by a group of investigators in Canada, which was published in Injury Prevention. They found out that unintentional injuries in children younger than 5 years of age, specifically drowning and falls, leads to significant mortality, substantial in such children. And it is the 6th leading cause of death among children in this age group. What are the types and patterns of injury? Now, children and adolescents have unique developmental characteristics which influence their injury patterns. Children, we must expect a multi-system injury as a rule until otherwise proven. Majority of injured children remain hemodynamically stable during the treatment part. A word of caution here is to evacuate the rapidly deteriorating trauma child to a higher facility at the earliest, if one doesn't have facilities to manage a pediatric trauma patient at your center. So to facilitate scoring, there is a pediatric trauma score which identifies children with multi-system injuries, which goes like this. The best score in this is a +12 and the worst is a -6. So the 6 components that are assessed in the pediatric trauma score are the weight, the airway, systolic blood pressure, level of consciousness, fracture, skin conditions. So as I mentioned earlier, the best score is a 12 and the worst is a -6. A -6 child should be immediately transferred to a higher center as early as possible. So what are the unique characteristics of pediatric patients? The initial assessment and management priorities are the same as that for adults. These have been discussed in details by my predecessors. However, there are some unique anatomic and physiologic features in children which should always be remembered and recognized as such. Now, children have a larger head size in proportion to the body. So the most serious injuries would be like a blunt head trauma leading to apnea or a hyperventilation and resultant hypoxia. Hence, it is important that the airway remains patent and the injured child is adequately oxygenated. So ventilation and so patency of airway and adequacy of ventilation are very important. They have a smaller body mass, which results in a greater force of impact per unit body surface area, hence greater destruction. Add to this the lesser fat and connective tissue causes the superficial vital organs results in vital organs being more superficial, hence greater destruction to multiple organs. The children are also more susceptible to hypothermia because of the higher ratio of the body surface area to the body mass. So there are more evaporative losses. And coming to the skeletal system of a child, there is incomplete ossification of the growth centers. The bones are more pliable. So this gives them an advantage that there are less frequent fractures in children. However, if you find a visible skull or a rib fracture in an injured child, that is an ominous sign. That is a sign that he may have suffered grievous injuries. The psychological status of the child is also very important to recognize. So, because the communication with the injured child becomes limited during history taking. So it is good that it is always beneficial if you have a caretaker, a caregiver, or a parent available to minimize the child's natural fears and anxieties, especially after a trauma. What are the long-term sequelae of injury in a child? So injury affects subsequent growth and development, as we know that a child is not an oversized adult, a small-sized adult. So he is still in the growing stage, and hence injury will affect his subsequent growth and development. There are significant potential physiological and psychological effects of injury, which lead to long-term functioning of the body. They may cause growth deformities or abnormal development as a result of the trauma suffered to growth plates, etc. Then, besides this, there are social, affective, and learning disabilities reported in 1/2 of severely injured children. So they have, learning difficulties, affective and adaptive difficulties after they have recovered from a serious injury. Injury to a child does not spare the family either. So it has been found that uninjured siblings, they suffer personality and emotional disturbances in 2/3 of the cases. And there may be economic hardships on the family, resulting in parental discords, parents having different working hours. So they may, the injured child may be at home, he may be missing out on his education, his schooling. So these are the long-term sequelae of injury in a child. Trauma in childhood involves first the child's survival issue. That is the most important first thing, depending upon the severity of his injury. And followed by this, if he survives and the outcome is positive, then the child's quality of life beyond his survival is also important. Bony injuries through growth centers can impair the growth in the affected bones. So it can lead to unequal growth of the let's say the lower limbs or the upper limbs. Solid organ injuries such as a splenic rupture, which is treated by a splenectomy, will predispose the child to infection, sepsis, and maybe he may succumb to such sepsis and die eventually of such a. Ionizing radiation during investigation of an injured child, they again increase the risk of certain malignancies in the future. So I'll be very brief on the ABCD. ABCs basically in a trauma child. So airway is initial assessment of the airway is the same as that for adults. Again, child's airway is the first priority, as I mentioned earlier, because airway patency and adequacy of ventilation are the top priority in resuscitation of a trauma injured child. A compromised airway is the commonest cause of cardiac arrest in children. How is the airway anatomy different in a child? See, there is a disproportion between the size of the head and the midface. So it would be preferable to avoid a sniffing position and keep a mattress under the mattress under the torso of the body, the child, so that the airway can come in alignment. Visualization of the larynx is compromised due to a larger oropharyngeal structures. The tongue and the tonsils are big, so the larynx is funnel shaped. The secretions can accumulate in the retropharyngeal area. Larynx and vocal cords are more anterosuperior in the neck. So this again makes intubation technically different in children, especially when a child is traumatized. The length of the infant's trachea, we have to keep in mind, is about 5 to 7 centimeters at the most. We have to avoid endobronchial tube placement by estimating accurate insertion using the formula either age in years by 2 plus 12 centimeters or 3 times the size of the endotracheal tube in centimeters. That should be the approximate depth of insertion of the endotracheal tube. Oropharyngeal airways insertion techniques is recommended is different from that in adults, wherein we put the airway directly into the oropharyngeal airway directly into without having its concavity upwards, like we do it in adults, so as to prevent trauma and hemorrhage into the soft tissues of the oropharynx. Nasopharyngeal airways should be avoided in children. Orotracheal intubation is generally drug-assisted or rapid sequence intubation is recommended. Do not attempt nasotracheal intubation in children. That is again, like we say, we avoid a nasopharyngeal airway. Similarly, we avoid a nasotracheal intubation in children. The main reason being that it may cause additional trauma, bleeding into the oropharyngeal cavity, or it may have a cranial migration. Rescue airways, LMA and the intubating LMA. Rarely, a cricothyroidotomy may be required, which could be in the form of a needle cricothyroidotomy or a surgical thyroidotomy. Again, this is done only in expert hands. So this is a flow chart of a drug-assisted or a rapid sequence intubation, which involves a pre-oxygenation, a mild sedation, depending upon the expertise of the clinical judgment and expertise of the performer, and muscle relaxation and intubation, and check the tube position. So next we come to breathing and ventilation. So the respiratory rate, like we know that the child has a respiratory, infants have a respiratory rate of 30 to 40 breaths per minute, whereas in older children it comes down to about 15 to 20 breaths per minute. So we have to maintain the rate of ventilation as well. Tidal volumes 4 to 6 ml per kg during normal quiet breathing, increasing to 6 to 10 ml per kg during assisted ventilation. And always keep in mind that there is an increased chance of iatrogenic barotrauma in such intubated and ventilated pediatric patients. Use of a pediatric bag mask device is recommended for children less than 30 kg weight. So we prevent hypoxia to avoid cardiac arrest. We prevent hypoventilation resulting in respiratory acidosis is the most common acid-base abnormality during resuscitation. So we have to maintain adequate ventilation and perfusion, keeping in mind that soda bicarb will further aggravate the hypercarbia and worsen the acidosis. So soda bicarb is to be avoided to correct the acidosis. Next we move on to the C, that is circulation and shock. So the challenges that are faced by the emergency physician or the anesthetist who is dealing the first responder is recognition of a circulatory failure or an impending shock in a trauma child. So accurate weight and circulatory volume assessment is important. A venous access is the most challenging job here. Adequate fluids or body replacement and blood replacement, I beg your pardon. Monitoring adequacy of resuscitation, and then maintaining thermoregulation. All these things go hand to hand. So the main pitfall in the management of circulation in a child will be failure to recognize hypovolemia and shock in a child. So how can this be prevented? This can be prevented by recognizing that tachycardia may be the only sign in a child who's bleeding. Children have a greater physiologic reserve. So the normal vital signs may vary with age, and careful reassessment of the child is very important. Let's say after initial resuscitation, in the primary survey, you find that the child has started developing a motor skin or a subtle decrease in his sensorium. So that should raise suspicion about ongoing bleeding process. So the normal vital functions vary with the age group, like an infant, toddler, preschool age, school age, and adolescent. So these are the various variations in the normal vital functions of a child, which one must bear in mind and resuscitate accordingly. The respiratory rate for infants is less than 60 breaths per minute. For a toddler, it will be less than 40. For a preschool, it's less than 35. And for a school age child, less than 30. For adolescents, less than 30 breaths per minute. So these are the normal values of these parameters. Now, determining the weight and circulatory volume is again very important, because you have all your resuscitation of your fluids and blood will depend on this. So the best person available is the if available, the caregiver is the person who can solve this problem. Otherwise, we have length-based resuscitation tapes. For example, the Broslow Pediatric Emergency Tape, which helps in a rapid assessment of the approximate weight, the respiratory rate, resuscitation fluid volumes required, and drug dosage. So it is very user-friendly, where you just keep it along the child on a flat surface, and you keep the Broslow emergency pediatric emergency tape along the thing, and you get your various drug dosages. You get your how much, what would be his weight, average weight, approximate weight, and then accordingly you can calculate. You can even know the amount of resuscitation fluids required and blood required. So then there are formulas for estimating the weight of the child in kg, like 2 times the age in years plus 10 is an approximate weight of the child in kgs. Then circulating blood volume estimation, again, the formula is very simple and easy to remember. 80 mils per kg for infants, 70 mils per kg for children 1 to 3 years, and 75 and 70 mils per kg for children over 3 years of age. So this is how you estimate the circulating blood volume and decide on the volume of resuscitation fluid and or blood products to be given. So our goal is to rapidly replace the circulatory volume to prevent shock. Guidelines for fluid resuscitation, weight-based to replace intravascular volume, warmed isotonic cystoids at the rate of 20 ml per kg bolus, repeat 1 to 2 times, titrate to physiologic response, desired response not seen with crystalloids. If then you can transfuse packed RBCs at 10 ml per kg. Now, there's a thing called the damage control resuscitation, wherein there is a restriction. There's a restrictive use of crystalloids with early administration of balanced blood products like PRBCs, fresh plasmas, and platelets. So this prevents the lethal triad of hypothermia, acidosis, and trauma-induced coagulopathy. So you start with initial 20 ml per kg warmed isotonic crystalloid bolus, followed by weight-based blood product resuscitation. So it could be 10 to 20 ml per kg PRBC, followed by 10 to 20 ml per kg FFP and platelets. Signs of improved hemodynamics, slowing of heart rate, clearing of the sensorium, return of peripheral pulses, return of normal skin color, warming of extremities, increase of systolic blood pressure, age appropriate, increase of pulse pressure, should be more than 20 millimeters of mercury, and a urine output of 1 to 2 ml per kg per hour, appropriate to the age. So accordingly, we have divided the children into responders, transient responders, and non-responders. So responders are those who respond very well to the hemodynamics, to the resuscitation, whereas non-responders who do not respond to the fluid and blood resuscitation, so they would need immediate exploration. Urine output to be maintained as age-appropriate urine output. Temperature regulation, again, because of their higher ratio of body surface area to body mass, there is greater evaporative loss and less subcutaneous fat. The skin is thin, so there is again increased evaporative loss and a higher BMI on children, so increased energy consumption. Now, this is very important. Remember, veins are capricious, and in an injured patient who is hypovolemic, it is really a challenging skill even in experienced hands. So the preferred sites are 2 attempts at a percutaneous peripheral vein. If not, then intraosseous should be attempted either at the anteromedial tibia or the distal femur. Then is the percutaneous femoral vein, a percutaneous external jugular, internal jugular, or subclavian vein, which would be done preferably by a pediatric expert. And this should be avoided if there's a cervical collar or an airway compromise. And last attempt would be a venous cut down or a venesection done at the ankle. There are some special scenarios, like let's say a child who has received a CPR for more than 15 minutes before arrival to the ED, or who has fixed pupils will not survive. So this thing should be kept in mind. Pediatric trauma patients reaching the emergency room with ongoing CPR of long-standing duration will not respond to prolonged resuscitative efforts. Then you have chest trauma, wherein 2/3 of the children with chest injuries will have multiple injuries. Mobility of the mediastinal structures makes children more susceptible to a tension pneumothorax, as discussed earlier, which should be treated immediately. Also, remember that a chest X-ray can identify most chest injuries in children, unlike in adults. So we do not go in for a CT scan immediately, because a chest X-ray will be able to identify most of the chest injuries. Abdominal trauma, some visceral abdominal injuries which are more common in children are blunt pancreatic injuries, small bowel perforations, mesenteric and bowel avulsions, bladder ruptures, decompression of stomach. So this requires a decompression of the stomach and urinary bladder, which is very important. Also, avoid deep palpation of the abdomen, because the child who's injured will be scared and he would not. There may be guarding, so you may cause your investigative findings may be difficult to assess. Head trauma, there are anatomic and physiologic differences from adults. They have a small subarachnoid space which provides less protection. Hence, parenchymal brain structural brain injury is more likely due to a head momentum. Children are more susceptible to cerebral hypoxia and hypercarbia, as I've already discussed earlier. So hypoxia has to be avoided. Secondary brain injury from persistent hypovolemia, hypotension, and hypoxia. This can take place while the child is under your care. So this has to be avoided by maintaining adequate ventilation and perfusion, as well as oxygenation. So it is very critical to restore and maintain appropriate circulating blood volume and to avoid hypoxia. Vomiting and amnesia are common in child, but after a brain injury, but these are not very severe issues. The child are more susceptible to impact seizures, which are seizures which occur following a traumatic head injury, but they are usually self-limited. Now, some children may have hypotension because of an obscured significant intracranial hemorrhage. Now, this is the reason for this is that they have these mobile cranial sutures and fontanelles, so they can obscure some bleed within the epidural spaces and the subgaleal spaces. So this can cause this which may be missed during investigations, imaging. So this can cause hypotension. Children are more tolerant to raised ICP, again because of their mobile the mobile sutures and fontanelles. So, however, signs of raised ICP may be obscure until a rapid decompensation occurs. So one has to be very careful. That is why the repeated reassessments is very important. Focal mass lesions are less common in children. However, a raised ICP due to cerebral edema is quite common. So that immediate cerebral decompression should be started by using mannitol, etc. Spinal cord injuries, fortunately, are less common in children. Muscular, again, as a word on musculoskeletal trauma in children, potential injury to growth plates can cause growth deformities. Crush injuries to growth plates, especially in the tibia or femur, can have the worst prognosis. The green stick fractures are more common because their bones are more pliable. Vascular injuries associated with supracondylar fractures at the elbow and knee are also seen. And a final word on child maltreatment. Now, physical and what is child maltreatment? It involves physical, sexual, and psychological violence to the child. It may be the result of neglect of infants, children, and adolescents by parents, caregivers, and other authority figures. It could be in the setting of a home, mostly, but in schools and orphanages also. So it is very important to recognize and report child maltreatment issues as well. So with this, I end my presentation, and I again apologize for the delay in starting the presentation due to technical glitches. Thank you.
So this brings us to the end of today's webinar, where unfortunately we had a bit of a problem, so we were delayed to a large extent. I will just see if there are any questions in the chat session. Ma'am, there don't seem to be any questions here. So I would really like to thank all the audience and the faculty for their patience for this webinar. And would you like to give some concluding remarks, Dr. Jayashree?
Sure, sure. Thank you so much, Shaloo, Vivek, and Niti, for this excellent webinar. The topic is very, very relevant, trauma, on which all three of them spoke different aspects of trauma, which are very critical in the management. And everything was discussed so well that nothing really, that's the reason that there are no questions over there. So really, Shaloo, it's all very well done. Thank you so much. And
you, ma'am.
wish you all a very happy World Anesthesia Day once again. And I think now it's a long day for you all since you are still in the OT, it seems.
Yes.
So thanks a lot and good night.
Good
Good
night,
night.
ma'am.
You're
Good night.
so
Good night,
nice.
ma'am.
Thanks
Thank
a
you, ma'am.
lot. Bye-bye. Thank you so much.
Good night.
Thank you so much, ma'am, for the wonderful deliberation and informative content that you have shared to make this session a success. It was pleasure to host this session. See you again. So with all your permission, we will end the session here. Have a good night to
Yes.
all.
Thank you so
Thank
much,
you, ma'am.
Swastika. Good night. Good night.
Thank you.
Thank you so much. Good night all.
Thank you.